I think episode 4 is the episode that Nikhil became an operator because he was plowing through all these tactical questions.
I mean, he taught us about where to A/B test on patient engagement. And then we started A/B testing on the podcast. I'd say that's live implementation. That's pretty good. I'll give myself a pat on the back.
Damn right. And we got to play a game.
And we did get to play a game. The game is, which of these messages do you think had the highest engagement rate? And so as you listen, you get to guess along too and see if you get it right.
Yeah, it was a great time. We learned a lot, and he really just shared all of his best practices and learnings from like 7 years of Aledade. It's no small feat. He has an amazing career story too. I really enjoyed this episode.
Yeah, we think you'll enjoy it too. So take a listen, tell us what you think, and there's some practical tips you can implement tomorrow at your org.
Welcome on, Doug. We are stoked to have you on. This is episode 4 of the project we didn't think would make it through 4 episodes. So giving myself a pat on the back.
That's commitment right there. 4.
Damn right. 4.
Doing 4 episodes. Well, we're excited. Doug has been part of our operations, knowledge fest sharing group for a while now. We've learned a lot from him, and so we're really excited to have him on. Doug, thanks for coming.
My pleasure. Thanks for having me.
Hard to pick a topic with you, Doug, considering your team is like hundreds of people and you do so many different things. But we decided today we'd talk about patient engagement and the magic kind of secret sauce you've built at Aledade around getting patients to be really active in their care. So that's what we're going to talk about today, but we thought it'd be helpful to kick things off with just hearing a bit about Aledade and the behemoth of your team and a little bit about that.
Yeah, sure. I'm so excited to be here. I've been sort of fangirling over the first few episodes of the podcast. You just dropped episode 3. I'll reveal that we're recording this just a few hours after you dropped episode 3, and I cram listened to it before jumping on today because I'm super excited. And Matthew had some great insights on AI. So anyway, glad to be here. Glad to be episode 4. I work at Aledade, which is the nation's largest network of independent primary care practices. We work with 1,500 practices all over the country, 45 states, totally agnostic to what market we work in. We serve more than 2 million patients, and we take risk in value-based contracts. We help primary care practices, many of whom aren't large enough to do this on their own, some of whom are, take risk, do value-based care, and do it really, really well. That's what we're focused on. And I've been here for a while. Aledade's existed for about 10 years. I joined around 7 years ago and have sort of been on the startup journey at Aledade. When I joined, we were about 100 people. Today, we're about 1,500. I personally have had a bunch of roles. I started as an analyst, writing SQL all day and thinking about building dashboards. Then decided that I didn't like sitting in a cubicle by myself for 8 hours a day and wanted to actually talk to people. Became a product manager, as is, I think, a tried and tested path for many people who have that experience. Loved doing that. Was recruited away from that work by one of the few people who probably could have done that, which is the CEO of Aledade, Farzad Mostashari, invited me to be his chief of staff, which I was honored to do for 3 years. And then I moved over to work on a business unit that we called Aledade Care Solutions to be the chief operating officer, which I've been doing for just under 2 years now.
Wow, what a journey.
What do you think is longer commitment? You working at Aledade or us doing 4 episodes of the podcast? Because it's kind of hard to pick between the two.
It's tough to compare, but I'm hopeful that you will see the same revenue ramp on this podcast that Aledade has.
Listen, we are looking for sponsors, so if Aledade is trying to get on. Yeah, actually curious, Doug, a small segue before we get into patient engagement. A lot of folks ask me about career paths in operations and like how do you grow within that role. I'm curious, as you look back, if you were to advise folks that are sitting in that cubicle listening, being like, I want to get into a more senior role, I want to lead people, I want to lead ops. What's something you would tell them to focus on?
I mean, the first thing I say to pretty much anyone who's asking me for career advice, and I have these conversations with my team all the time, is the perfect job is where you can find the intersection of what you're good at, what you want to be doing, and what is needed from you. I think ultimately when it comes to doing great work in operations, it's ultimately about finding something that you love doing, that you're decently good at, and that the company needs. And that last one, I think, is sometimes the hardest piece. It's like, well, what actually is needed from me? Sometimes, and especially sometimes, finding something that is needed that you also like can be hard. So sometimes I think in the early stages of a career, you have to compromise on one of those things. You might have to choose, like, you know what? I don't love doing this, but it's needed. Let me do that. But ultimately, I think the long-term goal is find a way to be useful and indispensable, and the rest sort of works itself out. That's the path that I think I generally took. And then there's also a lot of luck.
There's no task too low is the framing someone shared with me once, where it's like there's gonna be a lot of tasks that people in the business just don't want to do. If you can become the like dependable person to get that stuff done, it's much easier to like use those chips later when you need to, which I think is similar vibes.
Yeah, for sure. And I mean, and have the courage to do things that maybe are a little scary or uncomfortable. I mean, I think, Nikhil, you know that more than most people do.
I am scary and uncomfortable. That's true.
You should see his tabs. That's scary and uncomfortable.
Exactly.
So now you have a massive team that you manage. Can you tell us a bit about what that team functionally does in the organization, and just a bit more concrete?
Yeah. So Aledade, I sort of mentioned, we work on sort of value-based care with primary care. We're also a public benefit corporation, and our public benefit mission is to deliver better health, better care, lower costs, sort of the tripartite mission of healthcare, creating a healthcare system that is good for patients, good for practices, good for society. In practice, that means that what we're trying to do is really align a lot of incentives. We've been really focused over the first 7-8 years at Aledade on doing what's great for practices. And one of the things that we realized is that there's even more we can do. We can do stuff that's great for patients too, as an extension of those practices. We can serve patients directly as an extension of those practices. And that was sort of the genesis of Aledade Plus, where we started thinking about what are some direct-to-patient service offerings that we can do as an otherwise B2B business to help serve patients in the value-based care context. And that became the foundation that we built Aledade Plus on. And over the last 2 years that we've been working on this, we have built a pretty substantial operation of services that exist as an extension of the primary care practices we work with. So we're never competitive with our primary care partners, but we exist as an extension of them. There are things that maybe they don't have time to do, or they can't do, or they're not interested in doing, and they can refer to us, hand things off to us, and we can give those patients additional services that are good for them. And so today it's a team of about 250 people. They're focused on delivering care to patients as an extension of those primary care practices. It's about 100 people actually delivering the services, about 100 people doing what we call patient engagement, which we're going to talk more about today, and then a variety of folks in various roles doing product and operations.
You've referred to the function as patient engagement, which like is sort of unique because maybe other folks would just call it a call center, right? Like you have folks manning the phone, they're calling. It's like, why do you call it patient engagement, and like how does that change how you approach it from like a KPI standpoint, or like generally your operating philosophy around that?
Yeah, I love that question. I've spent a lot of time thinking about this over the last year, and I originally called it a call center, and then I was reminded that, well, there's actually a lot of stuff that isn't calling that the team does. We send this past year we've sent 870,000 pieces of direct mail, 600,000 text messages. We've printed 500,000 pieces of in-clinic materials that get hung up on the walls. So like calling it a call center sort of denies all the importance of all those other things that we just did. So folks were like, okay, it's not a call center, it's a contact center. Okay, so great. Contact center includes stuff that's not calling. But it's such a sterile term, contact center. For me, it conjures this image of like fluorescent light bulbs and cubicles in like a giant room with a bunch of people with headsets, and you can hear all the conversations that are happening next to the person you're talking to next to you. And that's not what it is. First of all, most of these people work from home. There's no center to speak of. They're sitting in their living rooms. And second of all, the goal isn't contact. The goal isn't calling. The goal is behavior change, it's engagement. And so to me, the two words in the phrase patient engagement matter. Patient is about centering the person that we're doing this thing for. It's not a sterile concept. It's a real person. It is a patient. And engagement is about centering the active thing that we are doing, which is engaging patients. And so patient engagement to me is a more descriptive, meaningful, human way of describing contact center type activities.
Did you see the tear drop on my keyboard just now?
You're speaking Danielle's love language of call centers.
Yes. But at the end of the day, the channels that we deliver the care often are the same channels that you would use in a call center. But it sounds like the way that you've approached each one of those conversations is distinct. Can you like give a concrete example or something of like what if you were to approach it as a call center and we get on the call, like I would do it this, but because we look at it as patient engagement, we do the same call, but architect it like this. Does that make sense?
So I think if we were a call center, the goal would be to get through as many calls as quickly as possible. Just like let's just like hit some productivity targets. That's the traditional call center kind of way of thinking. What's your average handle time is a very common call center metric, which is like how long from the moment you're on the phone to the moment you're off the phone. And you want to make that number as small as possible, because that means you're addressing the issue as fast as possible. For us, doing patient engagement, we actually do not use handle time as a metric because of the perverse incentives that I think it creates, which is your goal is to get off the call. In fact, your goal is to stay on the call for as long as that patient needs you on the call to address the issue. If a patient wants to talk to you about all of their medications, not just the one, you called about the fact that they missed their rosuvastatin pickup, but they're like, oh, hey, I'm having this issue with my Mounjaro. Can we talk about these cost issues that I'm having? You're going to talk to them about that because that's what they need. You're centering the patient. So I think that's probably an example of the way that we change the incentives for our agents and the folks that are doing our work.
This episode of Ops, I Did It Again is brought to you by me, because no one believes in me more than me. I'm teaching a Healthcare 101 crash course that starts soon. You can find it on the Out of Pocket website at outofpocket.health. We go over all the major stakeholders in healthcare, payers, providers, pharmacy, all those in-between acronyms that you've been too scared to ask people what they mean. We'll talk about how the money flows, major laws in the industry. It's the fastest way to get up to speed on U.S. healthcare. You can use the code IBelieveInMe to get $100 off.
So if not average handle time, what are some of the KPIs that you use to measure success?
Yeah. So every agent on our team has, I would say, 3 categories of metrics that we are holding them accountable to. One is productivity. So there is a productivity target. We don't use handle time, but we do measure calls per hour. Are you getting through enough calls in an average hour? But that is balanced by quality, which is we score calls using a rubric, and usually out of 25 points and 5-ish competency areas, 5 points each. And you're expected to hit a certain minimum threshold on your call quality. And every agent at Aledade Plus gets at least 4 calls scored every month, and sometimes more. So you're expected to be productive. You're expected to balance that with an appropriate quality. And then, of course, the third is you're expected to have effectiveness. So if you were churning through calls and getting off the phone super fast, we would see that your leading indicators of effectiveness were good. You might be choosing a call disposition that says, this was a successful outcome. The patient will fill the prescription. Okay, great. But then we have lagging indicators too that tell us whether that behavior actually happened. And so 7 days later, I'll look and I'll say, that patient actually didn't fill that prescription. So your call disposition, which was our leading indicator of efficacy, wasn't actually true. And we'll track that over time as well. So generally, are you making enough calls? Are they high enough quality? And then are we seeing the outcomes that we expect to see? Are the sort of kinds of KPIs that we track.
That's pretty interesting. I mean, you guys can basically mostly only do that because you have access to like a lot of different data sets too, and can connect the patient through them.
Yeah.
Super
totally.
Interesting. So one thing that we talked a little bit about when we were like discussing, some of the topics we want to get in is like the kind of like A/B testing you sort of do in this realm, right? So you have these metrics that you're, maybe judging the contact center or your outreach on, but then there's like the methods too, right? That you're probably testing and trying to see what works, what doesn't. Like, can you like tell us a little bit about some of the experiments you run, how you think about like experiment design, and maybe some of the stuff you've seen that might be surprising?
Yeah, this is one of my favorite things that I think is differentiated about Aledade relative to a lot of what I've seen in the market, which is this probably starts from having a founder who is an epidemiologist and wants to always look at data on pretty much every subject. I was just in a meeting a couple weeks ago with Farzad, who's Aledade's CEO and my former boss, who I love dearly, and he was literally like in a spreadsheet, like in cell P37, you use the truncate function. Like that's the level of depth that Farzad gets into when it comes to data. And so I think that permeates through our culture. Evidence is one of our values. And so we do pretty rigorous
You can take a person out of the Excel sheet, but you can't take the Excel sheet out of a person.
Definitely.
Moral story.
I'm trying to imagine removing an Excel sheet. That sounded very surgical. Like we got to excise the Excel sheet from his abdomen. Anyway, evidence is one of Aledade's values. We are really focused on making sure that we know confidently that the things that we are doing work, like legit work, not like they kind of seem like they work. Like academically, we know that they work. Randomized control trial, propensity match control, difference in differences, like real academic study designs on little things and big things, but also little things. This text message, we're going to do a randomized control test. We're going to have a holdout sample. We're going to have A/B testing, all the things. So maybe a good example of that might be a fun game. We sent this was a couple months ago, we sent 3 versions of a text message script out to patients. And the context here was annual wellness visits. Great value-based care visit, get a patient in, review all of their conditions, make sure that they're totally, doing great. And if they're not doing great, make sure that that's documented, that you have a plan to address their issues. That's sort of annual wellness visits, a core tenet of primary care. We consider it part of our core 4, one of our key techniques in value-based care. So we sent a text message to patients encouraging them to come in. 3 versions. Version A script was basically practice name, : now is the best time to focus on your health. Our healthcare team would like to see you for an annual wellness visits. Call us today to schedule, and then reply stop, help, message and data rates may apply, whatever. Version 2, patient name, : this is your practice. We haven't seen you in a little while, and we want to make sure all your health needs are taken care of. Call us to schedule your appointment. Scripting C was, hello from the team at practice name. Our records show that you are due for a checkup with us. Call us to schedule today. Which one?
I haven't even looked at the answers, and I am guessing it's 2. Danielle, what do you think?
Danielle?
I feel like 2, because there was like the trust thing and there was like the building empathy really early. And then I was trying to review my notes from Irrational Labs, who's a behavioral change consultancy that was part of Knowledge Fest. And they literally did stuff just like this, of like keywords. And I couldn't really pull it up in time to cheat.
Got to restudy.
Well, it turns out you're both right. So congratulations.
People want to just be told that like someone's looking out for them. They don't want to feel like they're part of a protocol,
Totally. And like starting with the patient name, I think was an important one of that. It's like Doug : like, okay, you're talking to me. This is not a spam message. And then, yeah, we haven't seen you in a little while. That feels so warm. You care about me. You miss me. As opposed to, our records show that you are due for a checkup with us. Sort of sounds like
that's what my dentist says every year.
Yeah.
On my birthday.
Mom telling me to do my homework.
On my birthday.
Exactly. Give yourself the gift of cavities.
Jeez.
So, yeah. And so specifically, we saw the A and C, about 23% of patients ended up scheduling an appointment. And on B, 27% of patients ended up having an appointment. So look, it's relatively minor differences, but it's also relatively minor differences in words that have a 4 percentage point difference in impact. So
I'm sure it all compounds also, right? Like you do a lot of small incremental things, and in the long term, it's probably like a very high engagement boost.
Yeah.
Have you? One of the things that I've heard be really important in the equation of booking is you've got that one point of conversion where now they're like actively engaged in booking it, but then having really, really tight booking times from the point that you like tried to book it. Did you experiment at all? And like, is there a formula around same day appointments? Like you need to have a lot of slots within 24 hours, or just kind of anything formulaic around getting folks into the office?
Yeah. So when it comes to actually scheduling what the practice is, which is what this text message was intended to do.
That was the word I was trying to get to.
We have a little bit less control over the practice's sort of direct schedule. So we can't control for that as clearly when it comes to the practice's schedule. In fact, we only were able to measure this pretty far downstream. We had them call the practice, and then we looked at billing months later to see what the impact was.
Whoa.
So that's what we did in this particular study. But we have tested that internally with our own scheduling when we reach out to patients. And we do see that same day appointment availability is really important when we're scheduling for comprehensive advanced care planning, for example. Not every patient wants that. Many of them want to, get mentally prepared and be in the right headspace. But some of them are like, yeah, I'm ready now. Transfer me. And you got to be ready to capitalize on that moment if they are.
Why didn't you just like send them a mailer to sign up an appointment? Like why'd you do a text in that case? Sounds like you've got the mailer game on lock.
Yeah, I mean, we actually did we did a similar campaign with postcards. This was focused on patients who were new to Medicare, so sort of a subset of the population. Well, Welcome to Medicare Visit is a sort of standard version of the AWV that's just a little bit different, but largely the same. And so we sent a postcard to patients who were turning 65. Welcome to Medicare. Come in for your Welcome to Medicare visit if you've elected Medicare Part B coverage.
Did it have a stock photo on it?
It did have it. There were several stock photo options, which we also test that sort of stuff too. But yeah, it had a stock photo, or I think we found there's some interesting feedback that sometimes stock photos, if they don't look like, we're like, okay, here's a diverse stock photo, lots of different people on this. You should see yourself in this photo. And then in some of our communities, folks are like, there are no diverse families that look like this in my community. So I actually feel alienated by this diverse photo rather than feeling like welcomed and included by this diverse photo. So that's been actually, like, from an equity lens perspective, sort of an interesting learning around healthcare is local, people are local, and depending on what community you're in, different kinds of visual identities will be important. And so we've also started creating, postcards that don't have humans on them, or that just have cartoons, or that just have, healthcare imagery, stethoscopes, stuff like that, various kinds of options that practices can choose from. But on this Welcome to Medicare Visit thing, where we sent a postcard on Welcome to Medicare Visit, we actually saw that it didn't work. The text message worked, the postcard didn't. And we spent a bunch of time reflecting on why that was. I think it largely has to do with a thing that I made a joke about earlier, which is that when you're about to turn 65, you are getting like a dozen pieces of mail a day from every single Medicare Advantage insurer trying to get you to sign up for their MA plan. And so,
I mean, the ads are crazy. You just see them on TV, you see them on the billboard, like they're everywhere. It's nuts.
Totally. And so I think we were probably just we were intervening at a moment that was already very noisy in patients' lives. And we were never going to make an impact on them coming in for their wellness visit. But we're still trying stuff like that.
What's like the last mailer that you were like, this is the dopest mailer ever, and like you're really proud of?
I don't have the results on it yet, but I'm feeling really optimistic about a mailer that we sent this fall. We called it the Care Gap All-in-One Mailer. And it's a mailer that summarizes all of the open care gaps that we believe you to have based on our data, up to 3, because we decided that if some patient, there's a long tail of folks there's not a lot of people, but some people who have like 8, and we thought it'd be a little overwhelming to get 8 care gaps in a mailer, but up to 3 care gaps that are high priority gaps: hypertension, A1C, medication adherence issues, colorectal cancer screening, breast cancer screening, whatever else. And it sort of walks through, here are the gaps, here's what you can do about, here's the reason why this is really important for you to do, and here's what you can do about it. We've seen that direct mail, like in envelopes that you have to open, is actually more effective in general than postcards, because it feels less spammy. Postcards feel like, here's another ad. When you have to open the envelope and it's in a windowed envelope, you're like, oh, maybe this is a bill, so I'm definitely going to open it. And then you open it and you're like, okay, I have to read it. And then once you're reading it, you're like, okay, I'm going to finish reading this. And so we find that that's and it's detailed and engaging, and it gives people tactical next steps that they can take for their health. And so it's good for the patient too. And so I'm pretty optimistic about this one having a big impact on our care gap closure rates this year. Stay tuned.
Isn't it sad that, like, if you get a postcard and you're like, postcard bad, and then you get like a piece of mail and you're like, ooh, might be a bill, and then you open it and you're like engaging with it more? It's like, that's like sad state of the world. I'm curious, like, do you have patients actually fill out what their preference of communication is, or like at the beginning, do you have like some guesses on what it is? Like, I imagine like that's a big part of this, right?
I so desperately want to do that. Today, we don't do that yet. I think it is the next frontier. I actually think this is a really interesting application of potentially of machine learning, where
Let's go. We hit it. We got there.
How long until I hit the keyword? Yeah, exactly. I think
we need it for the tags.
I think this is a really interesting application of machine learning, because seriously, you could say, like, what are the characteristics of patients that are going to be engaged most with a text message versus direct mail versus a phone call? And like, or even you could do this with visual imagery that I mentioned earlier. Like, what is the right kind of image to put on this postcard for this kind of patient, or for this patient specifically? I mean, with generative AI, you could literally have a custom image on every postcard for every patient that was specific to their context. I don't think we're going to go that far, but broader point is, we don't do that today, in part because it would be really hard to collect all that information in a consistent way in sort of a standard data format. But man, it would be such a treasure trove to know that. And we're starting to test that and learn. And as we build our sort of repository of results, we're starting to build the training set that one could eventually build an ML model from.
Yeah, I'm sure you have like lots of cohorts of people that, like, when a new person enrolls, maybe they look very similar to other patients that you're already taking care of, and can like start making guesses around how they engage, their preferred methods and all that kind of stuff. So super interesting. One thing I wanted to touch on a little bit is like the staffing that has to happen behind the scenes to enable a lot of the patient engagement stuff that you guys are doing. So I'm curious, just like, first of all, you seem to have staffed like extremely quickly, right? Like, I think one thing that a lot of people listening to this might, struggle with is like, look, if you have to start scaling very quickly, how do you maintain that level of like quality bar that you expect? A lot of, especially for things like this, where it's maybe more complex patients, there's a lot of training that goes into it. Like, curious if you have any like thing you could share with people on like what you've learned from quickly staffing up in org to support all these things you've been talking about.
And even deciding how much to staff up, to Nikhil's point around like forecasting, or like any tools that you think were good, like compasses in that whole journey.
This is really one of the hardest things. And I think we're still learning on this one. Workforce planning is top priority for my team. If you ask anyone on my team about sort of what I'm thinking about going into 2024, most of them would probably say in the top 3 things, workforce planning, because this year we actually didn't manage demand as effectively as I wanted to throughout the year. And we had moments where we had lots of patients who we wanted to call and we just didn't have quite enough people. And that's this like hard thing, because you also don't want to overhire and then have people sitting around without work to do. And matching supply and demand, especially in a world where it's inconsistent, is hard. So I don't have the answer on workforce planning, except to say that we're building our own models internally, looking retrospectively at what we've seen in terms of seasonality and trends in the past, and trying to model as best we can. What I can say is this gets easier once you have scale, because we can share resources internally. So I mentioned that we have several teams. We have a team of folks that's dedicated to making calls for comprehensive advanced care planning. We have a team of folks that's dedicated to making calls for adherence, folks that are dedicated to making calls for patient scheduling. And while those are their default positions, we have had moments this year where we've said, actually, we're going to move some folks from scheduling over to adherence, or from advanced care planning over to scheduling, because that's where there's demand right now. And so, I mean, this is just sort of queuing theory, operations, math. But the more you can generalize skill sets, the more flexibility you create for variance. So I think that's one learning we have generally. When it comes to actually hiring in the first place, I mean, we've been blessed with a pretty talented recruiting team. I think some of our learnings there are, one, having evergreen job postings. I think it's common to sort of post a job and then pull it down once you've hired the people you need to hire for that role. But if you're you're operating in a way that's sort of getting to scale, just like post it and have it there and let people apply on a rolling basis and keep the pool fresh, because you're going to have attrition and you're going to want to be able to pull from that pool. You're going to be looking to grow. You're going to want to be able to pull from that pool. So don't need to tie the job posting to a specific requisition number. And then when the requisition number gets closed down, you pull it down. That's a little too bureaucratic and formal if you're really operating an organization at scale that needs a lot of people who are the same kind of person. I think the other insight for us on hiring was to this is sort of like a classic traditional learning, but the sort of fail fast strategy of hire people, give them a chance, train them as best you can. And then if things don't work in the first 90 days, that's okay. Set an expectation that the first 90 days is a time to see if it works out. And if it doesn't, end on mutually good terms. We do that sometimes, and that's okay. Our work isn't for everyone. So that's the other thing I think is just making sure that you don't just sort of let issues linger if it's not working for in either direction.
Are there any like interview best practices or tips you've learned through talking to so many folks that others could adopt themselves? Questions or just like case studies, things that you've seen be really effective at assessments?
Yeah, I mean, one thing that I think we care a lot about is consistency in interviews. So easy to introduce bias into the interview process if you ask one candidate one set of questions and another set of questions. So we're pretty intensive about people asking, these are your questions. Ask these questions in the interview, and you are going to become an expert on asking these questions. That's the other thing. The more you ask the same sort of questions, the more you are able to calibrate on what a good answer to that question is. If you're asking different questions every time you interview, or you're sitting in a different slot on the interview panel every time you interview, then you're not becoming an expert as an interviewer. And honestly, interviewing is as much a skill. Being the interviewer is as much a skill as being the interviewee. So making sure that people are really like tight on what they're asking. That's sort of like number one. Number two is, I think there's all sorts of, we mostly ask behavioral questions for these roles. But I think you also want to assess passion for the work. It's hard work, patient engagement, particularly folks who are on the phones every day. It's emotionally intensive. You are on the phone with folks who are sick in some form or another for the most part. And you are talking to them about hard things, and you're trying to drive behavior change. You're trying to help them help themselves and help us help them. And that takes work, and you have to love doing it. If you don't love doing it, you're going to burn out. And so assessing passion during the interview process is, I think, a really key piece.
So for people listening to this podcast, obviously we like to leave them with some like practical tips and takeaways, and you're going to be our first test of like the most explicit version of that. If you were, this is our A/B testing, if you were to give like three pieces, like three experiments people can just run in their orgs today that are maybe like lower lift or easier just to test out that you guys have found have been very effective, what are like three things you think people should give a test?
Yeah. So I think the first thing that comes to mind for me there is you want to make sure that you're leveraging patient trust in your work. Healthcare is hard. It's scary, particularly if you work with seniors, as many folks do in healthcare. There's a lot of scamming happening out there. There's a lot of mistrust. Building trust is the number one thing you can do. And one strategy that we found really effective there on our calling is call masking, where we actually will take all 10 digits of the practice's phone number and call from that caller ID with the practice's name listed as the caller ID and their whole phone number listed as the phone number. What that did for us when we started testing that was took us from about a 27% reach rate when we were just sort of masking area codes. So like you have a 917 phone number, I'm going to call from a 917 phone number, and maybe the next 3 digits will be similar, but it's not going to otherwise be familiar. And that had about a 27% reach rate. Not horrible. That's over 3 calls. We would reach about 27% of patients. Not great. When we replaced that with the practice's phone number and the practice's caller ID, we jumped to 68% of patients are reached over the course of 3 calls. I mean, that's more than doubling our, like almost 2.5x our reach rate just from that one change. Huge impact. Another thought there is think about multimodal approaches. So we've talked a little bit about various modalities that exist. The best answer is not to choose one, but actually to create a coordinated experience across modalities. And we've seen success, for example, by little things. Text a patient a little bit before you call them to tell them that you're going to call them. Makes a big difference, so that when they see the phone number ringing, they're like, oh, maybe this is spam, but it's a spammer who had the courtesy of texting me before they called me. So clearly they care. And it just it makes a huge difference in breaking through and, again, building trust. And then, I don't know, the last thing that I would say is make things easier for your agents. We have seen that I mentioned all the agent productivity metrics earlier. One of the biggest barriers to agents being successful is not their skills or their knowledge. It's whether the tools we've given them and the processes we've given them are smooth. And we have done a lot of work, still have a lot of work to do to make those processes simpler. Stuff like, instead of making you copy and paste a documentation template into the notes every time you have to write notes, we're going to make it available for you already, or we're going to let you click buttons instead of free text. EHRs have done a lot of this to the point of annoyance, I think, for many clinicians. But there is a good in between where you're not just forcing people to freestyle their free text, and surfacing information to them that they need in the right moment without overwhelming them. Expanding modals automatically for them when they reach a page that's sort of in a way that's context aware to what they're trying to do when they get there. Those kinds of things go a long way.
Well, that was actionable as hell. Love it. If anyone wants to reach out to you, or there's things that they want to jam with you about, and they're trying to do their own A/B testing, like, what's the best way to get in touch with you, learn more about what you're doing?
Yeah, for sure. My email is very easy to remember. It's doug@aledade.com. That the benefit of being an early employee at a startup is getting the first name at. And I'm also a frequent Twitter/X lurker if you'd like to follow me or DM me there, and then also on LinkedIn, all of the above.
Can you give your address in case people want to send you?
Yeah, I need to send it. What if I want to send direct mail to you and flood the zone?
Shoot me a DM, we can talk.
You weren't part of Knowledge Fest this year, but
it's true. We know where you live. Just kidding. Yeah, we sent postcards out.
We sent postcards this year.
Nice.
We probably shouldn't say what they were in case we want to run it back next year.
That's true. That's true. It was a surprise.
All right. Now I feel like I need to sign up for Knowledge Fest V3 so that I can find out what these postcards are all about.
Heard it here first.
Exactly. Doug, thanks for joining us.
Thank you, Doug.
We'll see you soon.